Hereby I open this academic ceremony at Maastricht University. My name is Ton de Goey. I am the pro-rector of the ceremony and chair of the degree committee. First of all, I would like to welcome Mrs. Pascale Gränicher. She will defend in public her academic thesis, which is entitled Warm-up, Prehabilitation in Orthopedic Patients. Welcome all members of the degree committee, and in particular I would like to welcome the three supervisors sitting in front of me. Professor Rob de Bie, he is Professor of Physiotherapy Research at Maastricht University. Professor Ton Lense, he is Professor of Clinical Physiotherapy at Maastricht University and also at Utrecht University. And Dr. Jaap Zwanenburg, he is a Senior Scientist and Head of the Spine Health Group at the Bolgrist University Hospital at the University of Zurich in Switzerland. I will mention the other members of the committee, the 5 opponents, later, because when I mention those names now, you will certainly forget, so I do that later. And I would like to welcome the audience here in the aula and also all followers of the live stream. Mrs. Gränicher, may I invite you to give a summary of your thesis, and I wish you success in the coming hour. The floor is yours.
Thank you very much. Good afternoon. Today I like to share my PhD journey and where I explored the question if we have to warm up before prehabilitation. Are you ready? We often ask this before big events like an exam, a competition, or a presentation. But what is if this event isn't optional but a necessary operation? Patients usually lose strength or fitness after surgery, even if it goes well. Some get back on their feet very quickly, but others struggle and need support during their daily activities, for example, in grocery shopping. Increasing evidence suggests that the state of fitness before surgery can predict how fast patients recover afterwards and get back to their daily activities. That's why, just like in sports, warming up before an event might help to prepare for such a strenuous event, so-called prehabilitation. You can think of it like warming up before a race that doesn't guarantee that everything goes well, but it might increase your chance to finish strong. This simplified model shows how the usual timeline before and after an orthopedic surgery look like. After the decision for surgery, the functional capacity usually decreases until the date of surgery, then drops due to perioperative stress response, sometimes even below the level where assistance is needed. Afterwards, it recovers during the rehabilitation phase until full recovery. With prehabilitation, we want to lift this functional progression upwards and facilitate a faster recovery after surgery. That's just like the logic, better in and better out. So do we need to warm up? There is no consensus in literature at the moment. Some studies, they question if it's useful to prepare before surgery. Others did not find any benefits. And there's also a lack of high-quality evidence. So is it worth the effort to invest in this time period before surgery? Maybe we should take the effort and prepare, but the real question is how. To explore that, we looked into current evidence and did a meta-analysis on prehab before knee replacement surgery. And then based on those findings, we tested a prehab program within a pilot study and compared it to usual care. And to understand the patient's perspective, we also tested the feasibility of pain diaries and quality of life questionnaires. Since there were issues with the hand grip measurement in patients suffering from finger joint arthritis, we compared 3 different devices to increase the test quality. And finally, we looked into the transferability from knee replacement surgery to other types of surgery and did a scoping review on prehab concepts before spinal surgeries. Now I'm going to focus on the first two projects. Well, what does current literature say? We searched for randomized controlled trials, which include two groups, a control group receiving usual care and an intervention group undergoing prehab before knee replacement surgery, and the groups were assigned randomly. The prehabilitation program should include an exercise intervention, and the studies should investigate the self-reported knee function. So in the end, 14 articles qualified for meta-analysis. When we look at the effects we found before surgery, there was a significant positive effect for the patients undergoing prehabilitation. And this effect decreased over time after surgery until insignificance in the long term, so 6 to 12 months afterwards. In summary, we found a positive effect of prehab on knee function up to 3 months after surgery, but there was low to very low certainty of evidence. This was mainly due to issues on the methodological side of the study, small sample sizes, and the patients and assessors and physiotherapists usually knew in which group they were. The interventions were often underdosaged, so not always possible to gain a benefit, and they were not tailored to the individual problems or issues. And on top of that, there was a relatively high variability of the outcome measures the studies used, and several studies had unrealistic expectations on the long-term outcomes. Based on those findings, we designed a prehab program for patients awaiting knee replacement surgery who had a waiting period from 4 to 8 weeks before surgery. The program should be personalized and include exercise and education elements. To design a meaningful 4 to 8 week program for this patient group, we first looked into predictors and risk factors which influence the outcome of this type of surgery and which are relevant for physiotherapy. Patient-related factors include age, so older patients have a higher risk for infections and younger patients tend to have higher revision rates. Men have also higher risk for infections and women to not return to their functional level. And being overweight can increase both the risk for complication and also prolonged recovery. And low general fitness can impair the wound healing. Regarding the knee function, a low functional capacity before surgery, for example, not being able to walk or getting up and down the stairs, can also influence the functional capacity afterwards. And low muscular performance, for example, weakness of the quadriceps muscle or postural control, make it also more difficult to return to daily activities. Mental health plays also an important role. So depression or mood issues can prolong the recovery time. Fear of movement makes it also more difficult for patients to return to their daily activities, and high expectations can increase the health usage, while low self-efficacy can lower the quality of life after surgery. And we should not forget the individual backpack every patient carries with experiences, expectations, and other health issues that can also influence the outcome after surgery. The key to our exercise program was to make it as difficult and as intense as possible so that every patient was able to participate. Therefore, every strength exercise, for example, consisted of 3 different levels. Here's an example for the hip abductor exercise, where level 1 was in a seated position, level 2 in a lateral position, and level 3 in a standing position. And by increasing the number of repetitions or adding resistance, we could also increase the intensity. The education part focused mainly on preparation before rehabilitation. So we practiced daily activities like getting in and out of a bed, a car, or the bathtub, using walking aids, getting up and down the stairs, and how to already instruct the exercises patients can do after the surgery in the hospital, and this was always nice for them to already know what to expect. And to test if the program was feasible, we included 20 patients in our pilot study, where we randomly assigned 10 to the prehab group and 10 to the control group without any additional therapy. We tested them all after decision for surgery under functional capacity and with questionnaires. Then the intervention period started for the prehab group, and we tested all the patients again directly before surgery, 6 weeks afterwards only using the questionnaires, and again 12 weeks after surgery with the whole test battery. Besides assessing the preliminary effects on knee function, we also looked at the feasibility of the recruiting process, so how many of the patients fulfilling the inclusion criteria participated in the study, if the program was safe and the patients adhered to it, how it fitted into the existing clinical workflows, and if the assessment battery worked out as we expected. We assessed the change of activity level and knee function with the Techner activity scale. This is a score ranging from 1, where patients are barely able to walk, up to walking, gardening, hiking, and in the end, competitive alpine skiing. And we see here at the beginning that the two groups have quite a similar activity level. Towards surgery, the control group decreases, while in parallel, the intervention group could increase their activity level and also keep that head start until 3 months after surgery. And even though the sample size was small and we have to be careful with the interpretation of these results, it can be an indication that prehab helps patients to stay more active before surgery and therefore return faster to more strenuous activities afterwards. So in summary, the program was feasible. We had a high adherence rate to the physio sessions with over 90%. There were no accidents and injuries, so it was safe, and the workflow was feasible, and we also had some first results regarding the knee function. But there's always a but. There were some difficulties with the recruiting process. In 35% didn't want to participate of the eligible patients. And we had these issues with the hand grip dynamometer, where patients suffering from finger joint arthrosis had pain, so there is an alternative needed. And we're still not sure who benefits the most from which part of our program. So now, do we have to warm up? Well, prehabilitation has a lot of potential, but it's not a one-size-fits-all. And we need to identify which patient groups benefit from what interventions, and also identify the relevant risk factors and try to reduce them, not just acknowledge them. And then tailor the interventions to the individual needs and expectations, and maybe create a real effect that lasts beyond the surgery table. Well, and then just, in sports as in surgery, if we warm up or skill up, this can make all the difference for a better out. Thank you.
Thank you very much, Mrs. Gränicher, for a clear summary of your thesis. The opposition will be opened by the chair of the Thesis Assessment Committee, Professor Tim Welting. He is Professor of Molecular Cartilage Biology at Maastricht University, and he is chair of the Department of Orthopedic Surgery at Maastricht University Medical Center Plus. Professor Welting.
Thank you, Mr. Chair. Dear candidate, it's a pleasure to be here. My congratulations with the finishing of your thesis. Also, of course, your team. I found it really, truly enjoyable to read it. Not only to read it, I think the layout is particularly nice. It's always very actually pleasant when you see that someone is paying attention and care actually to the things that other people have to read. And so I think even the tables have colors, which was particularly nice. And then I will stop with all these positive things and then move on actually to the questions. I think even the paper is nice because it feels nice. So thank you for that.
Thank you.
So moving on to the questions. So much of what you are describing actually, of course, is about prehabilitation. And prehabilitation probably means actually that the patients that you are working with, they should have the ability actually to be able to move, right? In order to do this prehabilitation, the patients basically need to be able to make the movements that you want them to make. So coming from an orthopedic surgery department, I quite often see, for example, how the knee joints look like when they are being taken out from a patient, and they look really bad. So I can hardly imagine that these patients are very, how do you say that, eligible in proper movement. So I would be interested in, well, knowing how you look at that and how efficient do you actually expect that this prehabilitation would be based on these impairments.
Well, thank you for the congratulations and your feedback on the thesis and for this question, highly esteemed opponent. Well, this question or this problem you describe is very known in our clinic as well. Lots of the patients there are not as mobile anymore, or they cannot even move to come to the clinic because they're not able to come with a car. And therefore, for this pilot study, we had some quite strict inclusion criteria that they had to be able to come to the clinic, for example. But I also think that there are parts of the program which could be done easily at home, for example, or in a remote setting, or focus more on an education side, so that we help them to prepare themselves on a mental level for surgery, that they know what to expect, because we have also seen that this already helps, even if they're not able to really work with their knee before surgery, that they are more confident and feel more safe to undergo this treatment. Yeah. And the exercises, they do not only focus on the knee joint, so it's also important to improve the whole functional capacity or the physiological capacity.
Okay, so because that is a really nice bridge to my second question, and it is actually basically wondering what you are basically training. Mm-hmm. Is it muscles? Is it indeed more the mental state? Is it more maybe like a systemic state? For example, we know that patients with obesity have this low-grade systemic inflammation in their bloodstream. If patients lose weight, this systemic inflammation goes down. Maybe that has a positive effect, or even, I can also imagine that an improved mental state actually helps patients going through that operation procedure. So have you any indications what you are primarily training in these patients?
Yes, there are some more ideas. I think the study is now some years ago already, so we're in a further state where we also try to have several modules, not only the exercise and mental training, but also nutrition, for example, plays an important role. But as you said, there are so many points to start with, so therefore it's really important that we screen for the patients which part of these interventions are really needed. And we included on the educational part, for example, also like daily tips how they prepare their home, for example. Often they have carpets at home, which are really dangerous if you have to walk with walking aids. And just to prepare their life after surgery, how do they arrange the grocery shopping? And if they have fear of movement, for example, if they don't, often patients come and say, I'm not allowed to move. And this is something where I think we can also combine the active part with the education part.
Yeah, so I was wondering, regarding the prehabilitation, if you would know better actually what you are training, then you could probably focus your prehabilitation program more actually towards these specific parts that have the most beneficial effect, right?
Yeah, because I think especially patients with other diagnoses, with also really ill patients which get an orthopedic surgery, I think it should be more an holistic approach where we look that the patients get more activity in their daily living before surgery, that they improve their breathing, for example, and that the stress the surgery creates is not something on top where it can get really dangerous and induce complications afterwards.
Okay. I would like to move on to my next question, because I see I'm a bit, I think, halfway through my time. So this is about chapter 5. Where you are actually working with the grip strength meter or devices, where I actually noticed that, the grip strength meter or device or trainer is somehow devised for patients that do have problems with grip strength, right? But you're using healthy individuals in order to assess this device. I was a bit amazed because on one hand, well, of course, somehow you need to benchmark that and you need to find people. But what amazed me actually a bit more was, you're right that, I think it's on page 100, it presents challenges for people with painful fingers and low grip strength. And then I think, yeah, of course, because this is actually where you have been designing this thing for. So I was just wondering, for me it feels like a contradictio in terminus there. Can you help me?
Well, the aim of this study was to assess if these 3 dynamometers could be used interchangeably or within the same study with using the same dynamometer for the same person. So we wanted just to assess the devices and not the population. We want to use it afterwards. That's why we wanted to include healthy patients.
But if you assess the device with healthy individuals, do you then expect that the feedback that you get or the data that you get from these healthy individuals is somehow representative of how the patients would be using them?
No. No, this was really just for us to be sure we can use it afterwards in a patient group. And I'm sure there should be new normative data now for different patient groups where we see if it works as we expect them. For example, the patients having issues with finger joints. But for us, this was just a baseline study to know that the devices work similar. And afterwards, the next step has to be that we test them in the certain patient groups with certain impairments and therefore see what values we get.
Okay. I have one question regarding a proposition that I will ask after my next question. Because you were mentioning in your presentation, and I was a bit triggered by that, because you asked yourself, how do you identify responders actually to the prehabilitation treatment? And I find that really interesting because in the osteoarthritis field, it's also a big thing nowadays. If you think about pharmaceutical treatments for osteoarthritis, we know actually that there are responders and non-responders, and you obviously do not want to treat the non-responders because it is quite costly, and clinical trials will also fail because of, for example, if you have your groups actually disturbed by that. So have you any idea how you are capable of identifying the responders from the non-responders for your prehabilitation? That's my final question.
Well, I think we need larger studies for that, where we can do some subgroup analysis of patients having just similar baseline functioning or levels in different outcomes, and then we can see if they have the same adherence to the therapy. That's often a problem in physiotherapy. Is there really a training effect if we do the same program, but they do not do it at home, for example?
Right,
so
that's compliance.
Yeah, exactly, that's then more the compliance part, but if they have the same predisposition, and so we have to identify with responding if it's more the physiological non-responders or is it more the motivational non-responders, and for that we definitely need larger studies to be able to do subgroup stratification.
Okay, thank you.
Thank you.
Thank you, Professor Welting. The next opponent is Professor Eimert Kant. He is Professor of Epidemiology, in particular Occupational Epidemiology at Maastricht University. Professor Kant.
Dear candidate, I've read your thesis with great pleasure. With your well-designed and well-performed studies, you have contributed in a scientific way to the body of knowledge on prehabilitation in orthopedic patients, and I congratulate you and your promotion team on this result. In your introduction section, you described that prehabilitation may consist of physical and/or mental preparation. But after that chapter, from chapter 2 onwards, the focus is solely on the physical intervention part. And you don't give a reason for that, and I cannot find it. You don't reflect on that in the discussion. But it's never too late to, because you don't have your bill yet, to pose this question. So My first question is, what were the reasons to solely focus on physical preparation? Can you elaborate a little bit on that? Because I know that you have limited time for all the studies, so you have to make choices, but I want to know the reason for the choice and reflect on that.
Thank you for your feedback and your question, highly esteemed opponent. Well, that is a good question because we mainly focused on the physical part of the prehabilitation since the intervention was also placed in the physical therapy department in our clinic. So the main focus was definitely on the physical side to prepare the patients, also including educational advices, but it was not as systematic as the exercise therapy, for example.
But I think that there is another reason for your choice, because I don't think you really believe that mental aspects could be beneficial in the prehabilitation, because for that reason I want one of your paronyms to read out proposition number 9.
Move your ass and your mind will follow. Narf relum trinity.
It's a proposition from another, but I think you accept this proposition because you placed it here. So I think that, do you really think that this is the case? That if you train on physical aspect, the mind will follow? Or could it be also the other way around? If you prepare for mental aspects, that the body will follow?
Yes, definitely, because we also see prehabilitation as this so-called window of opportunity to place a seed where we can maybe induce some behavioral change after surgery. And I personally see this definitely as a great opportunity. There are, to my knowledge, not so many studies already looking very deep into that part because it's, I think, more difficult to study. But I'm definitely not only on the S side in the beginning, but I think it's really important for the motivation to.
So we could have a proposition number 9A and a proposition 9B. Is that what you say now? Is this insight? Is it insight? Okay. Well, we are moving into the direction I really like, because in chapter 6 you describe the results of your scoping review. And from that chapter, it is very clear that also mental aspects should be included. That's your main outcome of that. Mental aspects both as a determinant or an outcome. And that makes sense because the demographics of an orthopedic ward resembles the demographics of a geriatric ward. All patients in the hospital are old, have comorbidities, so the mental aspects, fear for avoidance for falling or for moving, that are aspects which you can train for and perhaps make. So I didn't see it in your reflection in the general, but I was wondering, after you wrote chapter 6, did it change your mind about where the focus should lie?
Yeah, I think chapter 6 was actually also the chapter that brought the stone into rolling. I don't know if this is saying in English. And why we also include in the clinical project we're doing now a fixed education and mental aspect with the same priority as the exercise part, because we believe that, especially also in surgeries, I can imagine, I didn't have knee or spine surgery, but the spine surgery may be even more stressful for the psychological side, and also more fears are connected with this type of surgery. So yeah, I think this is very important to tackle this topic.
Yeah. I really like your answer. Thank you for that. My next question is a more methodological question regarding chapter 5. In which you describe the results of a pilot study on exercise and education-based prehabilitation. This was before you saw the light that should be also on mental part, but it was still on this. So you are excused for that. And in this pilot study, you find very promising indications that the intervention may have beneficial effects. And from that you conclude that based on this positive effect, it supports the conduct of a full-scale trial. But another aspect you mentioned that supports, in your opinion, the conduct of a full-scale trial is the conclusion that the adherence to the program was very high. And I totally disagree with this reason, because the high adherence to the program is, in my opinion, the direct result of your very strict in- and exclusion criteria. You selected people with you excluded people from which you had the idea that they would not adhere to the program. You can do that in a pilot, but if you say that's a reason to scale up, how would it scale up be then? Do you exclude still? Do you also in the full scale have these strict in- and exclusion criteria? Because in this study, always half of the patients you excluded by these stringent criteria. So how is it possible? How can you move from this pilot then to a full scale? Or should you then include patients, normal patients with some adhere to the program, some hesitate, and you have to convince them? Doesn't that reflect more reality then?
Yeah, definitely. That's also something we reflected after the study, that we have to, on one side, open up the inclusion criteria, because it's also a very, or a more low-risk population we targeted in this pilot study. Yeah. But also, it was important to know if this group adhered to the intervention, because if the motivated patients or healthier patients don't participate in the intervention, then we have to rethink everything again from the beginning. But for that, therefore, it was important that this worked in this sample. But now it is important to scale it up, but also to include the other patients with more diagnosis on the side, more comorbidities, and look how it works there with their adherence, and provide different settings. I think this is also an important
I fully
point.
agree. This is very nice, because you know that when you conduct analysis on an RCT, you have two possibilities: a per protocol analysis and an intention to treat. But with your fully stringent criteria, you made a population which always will fit into that. So I really like the answer that you have seen to broaden up this. Yeah. Okay, thank you.
Thank you, Professor Kant. The opposition will be continued by Dr. Martin Verra. He is director of the Institute of Physiotherapy and affiliated with the University Hospital of Bern in Switzerland. Dr. Verra.
Dear candidate, I also would like to join my colleague opponents in congratulating you and your supervisor team with this thesis. It's a very thorough work, methodologically sound and clinical very relevant and future-based, so congrats so far. Nevertheless, I also have some questions, of course. My first set of questions are about the topic of implementation of prehabilitation. And I would like to invite one of your paranymphs to read out proposition number 4, please.
For a successful implementation of physiotherapeutic prehabilitation into existing institutional and healthcare structures, a multi-professional approach with shared decision-making processes is key. This thesis.
Thank you. So, implementation has to do with 3 major things. First of all, I was wondering, before you started your pilot study at the Balgrist, the existing institutional and healthcare structures, the existing institutional structures at Balgrist, how was it before your pilot, before you introduced prehabilitation? Perhaps a short answer.
Yeah, well, thank you for your congratulations first and your question, highly esteemed opponent. The clinical pathways was whereas after the diagnosis for knee replacement surgery, there was usually a waiting period depending on whatever the next date was available. And then shortly before surgery, there was like a preoperative baseline assessment with anesthesiology and orthopedics and nurses, I think. I hope I didn't forget anything. But this was like, short, really short, some days before surgery. And after surgery, there's an individual rehabilitation phase, sometimes at an inpatient clinic for some weeks and sometimes directly at home.
Okay, so if I understand you correctly, then not a lot happened before surgery in those days, and although some professions were involved already. That's the second part of your proposition, a multi-professional approach. My question is, which professions do have to be on board? Who is involved? What are the different roles of the several professions?
Well, if I could wish, I would involve almost every profession at the hospital. But I think the most important ones are the orthopedic surgeons, which should really be also motivating the patients to use this chance now in our clinic, for example, to participate in a prehabilitation and to be aware of this open window we have and to use the waiting period. But it is also important, especially if patients or have more complex health issues, to include the anesthesiologists early in the process. So if there are difficulties also with medication and the narcosis, anesthesia, so that we can adjust that earlier and not like 2 days before, because that's also costly if you have to postpone the surgery afterwards. And also the physiotherapists, if they are conducting the exercises, for example, for sure. Maybe, if possible, psychologists for patients really needing more support on the mental side. And for sure, the patients themselves. I think these are also the very important participants in this whole concept, because without them, we also should maybe involve them more in creating progress.
Okay, thank you. The last part of proposition number 4 is about shared decision-making process, which is the key, as you state in your proposition. Based on your review of the literature, your pilot RCT and ongoing clinical practice, you already mentioned that, expertise, what is the toughest decision to be made in the implementation in prehabilitation?
Well, I think in this context, I mentioned it because I think it's very important to screen preoperatively for risk factors. And I think the most difficult decision is then who takes the decision. So who is in charge, or who has the final word it is necessary to do this kind of prehabilitation, no prehabilitation, or just the whole program of prehabilitation we have. And therefore, I think this is really difficult to decide if it's just one profession, or if we have a decision board, or if we have an instrument which can decide for us. But well, I think this is really one of the hardest decisions.
Okay, thank you. My second set of questions are about a topic which has already a bit been addressed so far. It's your definition and accepted definition of prehabilitation to improve physical fitness on the one hand side and to improve mental readiness on the other hand side. And reflecting on the results of the studies of your thesis with the knee patients, not the spine patients, with the knee patients, do you have any clues now to suggest that either the physical or the mental part is the most significant therapeutic component in prehabilitation?
Well, I think with the knee patients, if they have not a psychiatric diagnosis or really a mental health issue, which is not connected to the surgery, then the physical part is the more important part. But for me, the physical part also includes like practicing daily activities, which is also a bit educational at the same time. But it's not like really mental training, as it's maybe more common in patients suffering from anxieties or really fear of movement. And as I experienced it at our clinic, but maybe we have a bit more the low-risk patients as well, it's more important to get the patients moving than to work or to focus only on the mental part. If I had to choose, then I would, in this patient group, choose the exercise part.
Yeah. So the physical part, the training part, is the most important part of rehabilitation in this group of patients for knee surgery, if I understand you correctly. If you had to do your pilot again, the intervention, the training intervention for this group, what would you do differently?
I think I would design the exercises even more functional, because it was never our goal to increase, for example, hypertrophy in such short time period, but we focused a lot on neuromuscular innervation, so the patients were able to use their muscles again. But I would maybe focus a bit more on daily tasks to really prepare them doing stuff and encourage them to be more active, not only in the physio session, but also at home, and to allow them to take that after surgery as well.
Okay, thank you very much. No further questions for Rector.
Thank you very much, Professor Verra. The next opponent is Dr. Hanneke van Dijk-Huisman. She is a human movement scientist and physiotherapist, and as a doctoral researcher, she is affiliated with Maastricht University Medical Center plus Department of Physiotherapy.
Thank you, Mr. Chair. Dear candidates, congratulations to you and your team on your excellent thesis, which I've read with much interest. As a physiotherapist, I feel that it's important that more research is performed on rehabilitation, and your thesis has contributed to that. But I've also have some topics that I would like to discuss with you. So first, I would like to talk about conservative physiotherapy in knee osteoarthritis patients. Because you say that rehabilitation bridges the gap between conservative therapy and surgery. I agree with that, but in your thesis I couldn't find the content of conservative physiotherapy and the difference between that and rehabilitation. And in chapter 2 in your systematic review, you described that rehabilitation mainly consists of muscle strengthening exercises for the lower legs and general mobility, but to my opinion, that's also what the goal of conservative physiotherapy. So could you please describe the difference between conservative therapy and rehabilitation, and what the added value is of rehabilitation besides providing patients education on what to expect from the surgery?
Thank you for this question, esteemed opponent. This question is something I often think about, or I thought about during these years. And in our experience, the conservative therapy, or how it should be, is to prolong the surgery as much as possible, to help patients to live with the condition and to challenge their daily activities as good as possible without needing surgery. So there the goal is a bit different. We do not want to provoke during the conservative phase, for example, too much pain with maybe really high intensity training that works for some, but not for everyone. And the point where surgery is indicated, at this point, the patients should really not be able to improve at any point and suffer without being able to do their daily activities. And therefore, rehabilitation has a different goal. It focuses more on getting ready for this event. And it's also okay to increase the intensity during this phase and try to get everything out that is possible. And I think, therefore, it's also very important to explain to the patients that it is this foreseeable challenge we have now, and to get ready for it. And therefore, it's a bit more a short-term goal or perspective than.
Did you also incorporate training on pain levels, or did you evaluate the pain levels during your training?
Not systematically. We always had the threshold that if they had after the therapy session, the next day, an enhanced pain level, I think it was around 4, then we would decrease the intensity because it shouldn't be like 8 weeks of pain and hell, but we wanted them to comply with the intervention. But yeah, it was okay if they felt that they did a training afterwards, and if it's the local pain, they will get a new knee joint. They cannot make something. Yeah, you know what I mean. The joint is not going to break or something. Therefore, yeah, we tried to really go into conversation with the patients and explain that it's okay that they feel something, but it should not like keep the same level for 48 hours afterwards.
And how could the conservative physiotherapy have influenced the results or the lack of results in the different studies?
You mean how they could influence the... Sorry,
some patients may have had extensive conservative physiotherapy and maybe less effect is to be expected during the prehabilitation. So
also the education part was here important because we had patients, they said, yeah, well, I was in physiotherapy until now, why do I have to do prehab now? And there it was really important to explain that it is a different goal and that we do not only work on the knee mainly, also if possible, but they really have to shift their mind towards this event and maybe beyond, but that we have to really work together on this. And therefore it's also really important to have the patients in the boat with you during prehab, the same as in conservative therapy, but explain this difference as well.
I was also surprised to see in your systematic review that few studies focused on improving exercise capacity. And you didn't include that in your pilot study just as an optional exercise. What do you think that the role is of exercise capacity during prehabilitation for knee osteoarthritis patients?
Well, I think it's an important factor. We mainly didn't include it because it's more difficult to assess or it uses more resources with the CPAT analysis, for example, and it was easier. We included the 2-minute walking test, for example, as a small proxy for functional capacity. But I think it's very important, if possible, to also assess the overall functional capacity and the maximum patients can do also to screen for the risk for complications after surgery in high-risk patients, for example.
Then my second question. In our hospital, in Maastricht University Medical Center, we're currently seeing if we can implement prehabilitation within usual care. And based on the results from your systematic review and your pilot, would you advise us to implement prehabilitation in patients awaiting knee surgery?
Yes, I would definitely advise that. I mean, the first step is maybe difficult to get it into the clinical workflows. I think that's the most difficult step. But I think the positive thing of prehab is that you can start very small with some preoperative education and how to use walking aids. I think this is also something that can really help some of the patients. And maybe it doesn't have to be a multimodal, multi-professional program from the start, but just to increase the awareness of using this time, I think this would definitely be worth.
So you feel that there's already sufficient evidence to implement it?
To start with it, yes, I would say.
Okay. Because our Dutch National Health Institute doesn't see that there's sufficient evidence, so they don't reimburse prehabilitation yet. So we either would have to convince our board of directors to invest money in prehabilitation, or we would have to perform another study to gather more evidence. If we go for the first option, to convince our board of directors, what evidence is there right now that we can use to convince them to invest in prehabilitation?
Yeah, well, as far as I know, there are studies that show that the preoperative, for example, functional capacity has an effect on complication rate and also on the length of stay, for example, which is economically interesting for hospitals. If the discharge criteria is how the medical condition is and not influenced by organizational limitations. Therefore, maybe there is not evidence for a specific exercise program that works for a specific outcome, but I think there is enough evidence on generally improving the medical or the health state of patients and limit some of the complications afterwards, also on, in high-risk patients, for example.
Thank you for your answers.
Thank you, Dr. van Dijk-Huisman. The fifth and last opponent is Dr. Bart Bongers. He is a medical and clinical exercise physiologist, and he is assistant professor at the Department of Nutrition and Movement Sciences at Maastricht University. Dr. Bongers.
Thank you very much, Pro-Rector. Congratulations on reaching a major milestone in your pursuit of a doctoral degree, and also would like to extend my congratulations to your team. I read your thesis with great interest, and what immediately caught my eye was the inside cover of your thesis, where you quote that major surgery is like running a marathon and that both require training. And there's no doubt about that, in my opinion. But for someone based in Switzerland, I would have expected a different metaphor, maybe something like major surgery is like climbing Matterhorn and both require training. But maybe on a more serious note, there are a few points that I would like to discuss with you about who requires the preoperative physical exercise training, but also what should the program consist of. And well, being quite busy for your parent, but can she also read Proposition 1?
An evidence-based risk screening can assess whether personalized prehabilitation is indicated and, if so, what type is appropriate. This thesis.
Thank you very much. As I browsed through your thesis, I noticed that the topic of evidence-based risk assessment or screening is not addressed in any of the scientific papers. And in Chapter 3, the pilot study, you also do not apply any risk stratification yet. And I believe that a formal risk assessment is essential to provide cost-effective prehabilitation. So in your opinion, what should be the purpose of your risk assessment? So what information should it give to you?
Thank you for this question, esteemed opponent. Yes, the screening or the importance of the evidence-based screening was like more a learning after or in the process of my thesis. So I think it is very important on if we want to scale up prehabilitation, because we cannot apply all the interventions we think are beneficial to everyone. So we have to identify the ones that need training or education or nutritional supplementation or maybe medication to reduce the individual risk factors. So we first need to know if we have a type of surgery, what are risks for unsatisfying outcome or a poor outcome, and then we have certain types of patients, which are sometimes the same in different types of surgery, and see what they bring risk factors with them, also smoking or personal habits. And then we should find a way to identify those who need really support before surgery. There may be some patients which can go home with a leaflet saying don't drink before surgery and stay active, and others which really need one-on-one clinic-based rehabilitation.
Okay, so if I listen to your answer, you want to use it for patient selection, but also to apply a multimodal risk assessment to maybe personalize the prehabilitation program, and also to have it a cost-effective intervention. And from a more physiotherapy point of view, what constructs of physical fitness, because physical fitness is an umbrella term, it consists of many components, what should be focused at from a physiotherapy point of view for the risk assessment?
Well, I think there are also the daily tasks an important factor. So are patients able, for example, knee replacement surgery patients, to do their daily walking or getting up and down the stairs, not just the isolated muscle strength of the quadriceps, which maybe not, it may be nice if they can extend their leg better after surgery, but they also need to be able to walk up and down the stairs. So we have to think here more functional, I think, in combination with some isolated factors. But I think from the physiotherapist's approach, function is the main part, but also fear of movement, for example. So how is how do they like to move, or do they have anxieties for something?
So I think the components that you want to address in your risk stratification are only relevant when there is a clear association with the short-term outcomes. Is there any evidence about that in the literature? What is really associated with worse outcomes, for example, after knee surgery or spine surgery?
Yeah, there is the part of the walking. So if patients have really difficulties with walking, they struggle more to get back to walking, because usually they have problems, especially with knee arthritis, for several years, and they have walking patterns that are like not physiological anymore, and surgery doesn't solve that. So we have to look how patients can adjust in this time before, and otherwise they may need more support from our side.
And do you expect differences between patients undergoing knee replacement surgery and patients undergoing spinal fusion surgery, for example? Are there other risk factors based on the physical components? Should you have a different risk assessment in these different populations?
I think partly yes, not everything. I think there are also assessments which can be the same, for example, walking or getting up and down the stairs. Maybe spinal surgery patients which have sometimes also an additional component with leg pain and back pain. There is maybe the balance also a topic, or the fear of movement, maybe more than the knee with the knee patients. But I think there are some activities that can be the same.
And if you would need to do an educated guess on the fraction or proportion of patients who would be considered at risk based on their physical fitness, what would that be for the knee replacement surgery, for example? How many patients will be defined as high risk based on your assessment? So who should we offer the prehabilitation? How big is the population?
I mean, any form of prehabilitation, I would say, is for 80% at least indicated. But if it's really one-on-one therapy and over like 8 weeks, I think in our population we have at the clinic, it would be maybe 30%. Okay. I would guess.
Okay, thanks you. I would like to move to a second part of my questions. The title of your dissertation is Warm Up. It also caught my attention because you also applied the eye content tool to look at therapeutic quality of the exercise programs. And when considering the eye content tool, I wouldn't expect a warm-up on its own to fulfill the requirements of, for example, item 2, the dosage of the exercise program. So how are you going to make sure that the program is also intense enough for short-term adaptation, so short-term response on the part of physical fitness?
Well, it shouldn't definitely be not only a warm-up. We already discussed that sometime. It should be a skill-up. And it is very important that we actively use this time period before surgery. And I think for some patients, even warming up would be more than they would do without rehabilitation. But it's very important to try to really take the maximum out of this time. So if patients are not are really motivated to do something, and we should support them in doing more before surgery and not just moving their toes.
When would you start with the prehabilitation program? Because often there's quite a long, well, we often say waiting list, but it should be preparation period, of course. When would you start with prehabilitation? Because I can also expect if you start too long before the surgery that patients will be demotivated in the end because it's maybe not that urgent for them to prepare. So what would be, in your opinion, the optimal starting point for prehab?
Well, it will depend on the type of surgery and on the backpack the patient carries with additional medical conditions. I think there is a study that recommends 4 to 8 weeks or identifies it at the perfect time frame. But it depends on what the goal of the prehab is. Is it to improve some muscle neuromuscular activation, or is it just education? Then maybe one session is enough. So I think there as well we have to think a bit more individualized. And if I would have to just choose a time frame and say we work with that, I would choose maybe 4 to 8 weeks. So I guess that's not a bad.
Yeah. And maybe that's interesting to me, because in chapter 2 you also evaluate the long-term effects of prehabilitation before orthopedic surgery. So is there any rational or maybe biological plausibility for the short-term 4 to 8 weeks of prehabilitation that results in also maybe long-term behavioral change, maybe long-term effects of the program before surgery?
Yeah, on a physiological side, I guess less than on the educational side, because we can induce a behavioral change, but I don't think that the exercise training alone can provoke a long-term effect.
Mrs. Gränicher, as you hear and see, the time for defending your thesis has passed. The committee will now withdraw to discuss the quality of your thesis and in particular your defense. And please await our return here with the results of our deliberation.
Thank you.
All right, please.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Southside, 7 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and that. All your time, 'cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and that.
On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off.
The mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. Even though these nights seem long, I know that I am never on my own. Know you won the battle once you've grown. Southside, 7 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and that. Long road to the south side, 7 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and that. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Mrs. Pascale Gränicher. The degree committee has assessed the quality of your thesis and in particular the quality of your defense, and in view of its positive verdict and taking into account the previous qualification that you have obtained, the committee has decided to grant you the degree of doctor. And Professor De Bie is authorized to confer upon you this academic distinction in accordance with Dutch university custom and law. And I invite your supervisor now to take the floor. Professor De Bie.
All right,
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent and responsible?
Yes, I promise.
So now you're married to science, and now the rest. By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Pascale Doris Gränicher, the degree of doctor and grant you all rights attached by it to custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary and the other members of the committee and affixed with the official seal of the university. Dear Dr. Gränicher, dear Pascale, it is with great pleasure and pride that I congratulate you and with your new academic distinction. You really deserve it and you did it very well. Jaap, Ton, Johannes and I are very proud of you. This is the moment you can cool down while I congratulate your family and friends. We met through Jaap. Actually, he sent me a mail. October 1st, 2019, in typical Jaap style. Mails from Jaap go like this. Hi Rob, everything okay? Here in Zurich, everything is going okay as well. An ex-master student of mine wants to do a PhD. She did her master really well and we submitted her thesis for publication. At the Department of Orthopedic Surgery in Balkris, they have a new department looking into prehabilitation. Oh yes, and Professor Johannes Scher is willing to be her co-promoter. I offered her to contact you. CVs included. Cheers and beer, Jaap. Well, typical Jaap. After some mails and between Jaap and me, you contacted me. There it goes. Dear Mr. De Bie, I was very excited when Jaap told me you may be interested in supporting my candidature. I had various discussions with Jaap about applying for a PhD candidature and was held a bit back due to the limited possibilities for physios, especially in Switzerland. But when he told me about Maastricht, you, yourself and your products, I had a really good feeling. And then the mail continues for almost 2 full pages and concludes with, well, I hope you're not overrun by my introduction. I also like to write, smiley. Well, we quickly assembled a team and got to work. Already very quickly we were impressed by your work style. Always friendly, but really hardworking and optimistic. Your past athlete's attitude got the oomph in the project and your sunny character the optimism. Just as we were going full swing, COVID hit. We fortunately were preparing a systematic review, so we switched to Zoom, Skype, Teams and what else, and you teamed up with Loes Mulder, and although you are really different characters, you got and get along really well. You two had your own Skype meetings, and in the meetings we could pretend that the outside world had gone a bit mad while we worked on. Soon we established a good team, with you and Loes, Johannes, Jaap, Ton and me. Besides the hard work, the meetings were productive, there was always a good atmosphere. You and Loes kept notes, made fantastic schedules of progress and project deadlines. We were never fully met, but had wonderful colors, just as in your thesis now. So it was fun. What also saved us was kind of an iron schedule. Every week on Thursday from 14:30 till 15:30, we had a meeting and there were always notes. And just to give you an idea, apart from all the meetings that we had, I have more than 500 mails on your project. It gives you some idea of the conversation that went on. Slowly the world turned normal, but we kept the schedule. Sometimes we could not all be present. Ton had the occasional council meeting. Johannes was sometimes off for the Olympic Committee or car races as a medical officer. And Jaap was in his airplane doing zero gravity stuff that no one wants to know about, but sounds cute. But you were the glue that kept us together and the elastic band that propelled us forward. As in every project where patient inclusion is needed, you also faced your challenges but overcame them. We also enlarged the topic of prehabilitation to spine patients, a bit surprising to some, and you became more adept at managing the project and us. Actually, you managed one of us so well that you and Johannes fell in love. We did not see that coming, although Loes really found us stupid for not noticing. Hey, Loes, we are males, right? You have to put stuff like that on our foreheads with a waterproof marker, otherwise we will not notice. However, the relationship between you and Johannes gave us two issues. One, the university directive states supervisors and co-supervisors may not be partners of the PhD candidate, not have a first or second family degree or ties with the PhD candidate. That effectively removed Johannes from the team. But the second issue was even more worrisome. Why Johannes? Why not Jaap, Ton, or even me? Jaap is the nice guy who does funny stuff in airplanes. And Ton is very good at skiing. I'm a decent cook. Well, it took us some years to process this. Anyhow, Johannes is a fantastic person. Congratulations again. And although roles changed in the team, we continued to work as old. And suddenly we were in 2024, and articles were submitted, rejected, accepted, etc. The end sprint was there. You never relented, stayed optimistic, still managed to write many words and very long sentences, which we lovingly erased, just as your German teacher did. And you managed a general discussion that as a first draft could serve as a thesis on its own, but we reduced it. And then suddenly we were in Valence, April 4th. You did your mock defense and it felt you were ready. And today you have proven this to be true. Again, many congratulations. Enjoy this day to the fullest. I've said.
Esteemed Dr. Gränicher, dear Pascale, it is my pleasure to congratulate you with your doctorate, and I do that also on behalf of Maastricht University. And also, I would like to look back with you over this ceremony. First of all, I would like to compliment you with a very clear, what we call a presentation for non-experts, a layman speech. And I think it was very clear, and I hope also that people that have watched you during and heard you during the live stream and the audience here understood what you have done in the last couple of years. With respect to your thesis, the committee found it enjoyable to read, interesting, and also it shows sound methodology and solid studies, and the majority of the studies have already been published as well, and I think one or two underway. With respect to your defense, we are very satisfied with that. It is done very well, confident, adequate answers to some challenging questions. And also it showed us that you have, not only that you have learned during your PhD period, but also during this opposition. Even then comes out you are very eager to learn. And also I think that we might say that you have shown to be very knowledgeable in your field of study, but also demonstrated that you have become an independent scientist. I do not only congratulate you with that result, but also your 3 supervisors. Looking back at the thesis, at the presentation, at the defense, I would, and also at the published papers, I congratulate you. And I hope that you have also enjoyed the time of guiding the young doctor during the last couple of years. I would like to include in my congratulations your family, your partner, I believe that they are sitting on the 2nd row, your parents, and I understood also your 2 Paralympics, who also includes your sister. So congratulations with the young doctor that stands in the middle of us. I would like to thank the committee, both committees I have to say, the thesis assessment committee and this degree committee. Thank you very much for critically reading the manuscript. And I would like to thank you on behalf of, and in particular, the external member. Thank you for having good scientific questions and a good discussion about the results and about the thesis. I would like to, before I close this ceremony, I would like to invite you to the reception. We as committee, we will have first a photographic session in the hall of the building, and I would like to invite your close family and the Paralympics to go with us to take a picture, and then we will move to the rafter for the reception. Hereby I close this academic ceremony at Maastricht University.
All right, please. Let's also meet now. Achter de blom. It's the most important document.